Hey class, let's start back with part 2 of sensory and some common causes of conductive hearing loss. Impacted cerumen or earwax. This can more so happen with an older patient sometimes, anyone really, but check your older patients if they're having trouble hearing to see if they have impacted earwax. Cleaning the outside part of the ear that you can see, not inserting any Q-tips or bobby pins, of course. Labyrinthitis also can be a cause of conductive hearing loss. Otosclerosis, which is an overgrowth of bone, typically by about age 40, and surgery can correct this. Trauma and scarring of the tympanic membrane or congenital malformation of the outer or middle ear. Also, you can add underneath this, arteriosclerosis can also be a cause of conductive hearing loss. And also add, when they're talking about trauma and scarring of the tympanic membrane, your tympanic membrane loses its elasticity with age. And also the auditory bones and joints stiffen with age. So when you think about conductive hearing loss, you're thinking about the transmission of the sound. So keep that in mind if you're having to choose which type it is. Many times conductive hearing loss problems can be fixed. So keeping that in mind also. But like I said, add arteriosclerosis, tympanic membrane losing elasticity with age, and auditory bones joints stiffening with age. Okay, and then when we move over to sensory neural hearing loss, presbycusis is hearing loss associated with aging, heredity with congenital loss, ototoxic drugs, loud noise exposure, acoustic neuromas, Meniere's disease, severe infections such as measles, mumps, meningitis, or rubella in utero. People who are over 75 years old can have a 40% hearing loss. And 15% of hearing loss is due to loud noises, and there are 36 million people with hearing loss in the United States. Nerve atrophy is a reason for sensory neural hearing loss. The sound receptors lessen with age, and all this is listed out on page 583. And when you think of sensory neural hearing loss, more than often these cannot be fixed. Okay, so let's talk about ototoxic drugs for just a second. Okay, when your patient is taking an ototoxic drug, it talks about assessing them frequently for hearing loss. This is on page 586. Some common medications that are in your book that can cause ototoxicity are listed. There's also some you may not think about more often. Nicotine also can cause this. NSAIDs, types of chemotherapy, aspirin, antibiotics. Older people are at greater risk for ototoxicity. This is on page 584 in a box 25.2. Some drugs that more often are not ototoxic are warfarin and Tylenol. So that might be a better choice sometimes for your older friends. Diagnostic tests and examinations. When a patient comes in that's under your care, one very easy way that you can test their hearing is called a whisper test. So read through a whisper test. It's on page 1228, when basically you just stand beside the patient and have them cover up the opposite ear and whisper a phrase or a word and see if they can understand what you're saying, and test both ears. Also, other diagnostic tests and examinations, of course, you're going to visually look over the outer portion of the ear. I have seen babies that are born with malformed outer ears. Sometimes that's associated with some other birth defects or congenital heart defects also, but do visually examine the outer portion of the ear. And your book also talks about tuning fork test on page 1230. Tuning fork, you'll see some pictures. There's a rind test where you strike the tuning fork, hold it behind the ear on each side, and have the patient raise their hand when they no longer hear the sound. So that's a rind test basically. And a Weber test is when you strike the tuning fork, put it directly on top of the head, and see if their hearing is equal in both ears. So that's a Weber test. Also, there are tests for nystagmus, also electronystagmogram, and this is to check for vestibular function, vertigo. And anytime you see a test for balance or nystagmus, vertigo, make sure you always maintain patient safety. That's always going to be an issue. Also, a Romberg test, we've talked about this before, but it's a test for balance where the patient stands in front of you to check and see if they sway. And so you want to stay close by the patient, of course, during that test. So read through all those diagnostic tests and exams. You also have a picture of a caregiver examining the patient's ear with an otoscope on page 586. And generally, when you're speaking to a patient with a hearing loss, speaking in a low-pitched tone is better than a high-pitched tone. Low-pitched tones, they're going to be able to pick up your voice better because many times older patients who have hearing loss are going to lose their ability to hear high-pitched tones first. Okay, oh, here's your picture examining with an otoscope. So you see they've pulled the pinna upward and outward for the examination. Also read through irrigating the ear. Whoops, excuse me. In your book. General goals for a patient with problems of ear or hearing. Protecting hearing by giving knowledge about protecting hearing. That could be just as easy as when a younger person comes in wearing earplugs if they're going to go to a concert, something like that. Prevention of infection and injury, promoting effective communication, and promote coping with the hearing loss. Okay, communicating with the hearing impaired person. More than likely, this will be on your test and on your NCLEX. If the person uses a hearing aid, encourage its use and see it situated, turned on, and adjusted. Be certain you have the person's attention before beginning speaking, directly facing them. And sit facing the person with the light on your face rather than from behind you to not obscure if they're trying to read your lips somewhat. Ask the person to turn down the volume or turn off the television or radio, especially if you're giving some instructions or trying to do assessments. The best distance for speaking to a hearing impaired person is 2.5 to 4 feet. Place yourself at eye level with the person. Do not speak directly into the ear because it prevents the person from visual cues while you're speaking. Don't smile, chew gum, or cover your mouth while speaking. I guess this is coming into play a lot with those who are having to wear a mask. You may have been faced with that at your job. So generally making sure you're facing the person, very important. Use short, simple sentences. If they don't respond appropriately or don't seem to understand what you're saying, try your message again using different words. Give the person time to respond to questions. Ask for feedback. Did you understand? And somewhat tell me what I said, rephrase it so they can tell you what you just taught them. For example, if you're teaching them about when to take their antibiotic and you've told them to take it twice a day, in the morning and at supper time with food, then have them repeat that back to you. Avoid using the intercom system because it may distort sound. I have worked on floors where they put a piece of tape to flag the call light so they'll know that someone has a hearing impairment. If a hearing aid does not work, check to make sure the switch is on. Examine it for cleanliness, make sure it's clean, check the battery, check the connection between the ear mold and the receiver. Usually batteries need to be replaced, it says here, every 12 to 14 days. You may still see some test questions about this, but I know now there are even today some more advanced hearing aids where they're not using batteries and they're charging it, so they could have something like that as well. And it talks about cleaning the hearing aid here. Be sure and read through that. And like I said yesterday, make sure you hold it over a towel on a counter surface so that it's not dropped on the floor. Common problems of patients with ear disorders, of course, hearing impairments, dizziness, and vertigo. Like I said, anytime you see a question about dizziness and vertigo, always maintain your patient's safety. And we'll learn about Meniere's disease is a disease that can cause a lot of vertigo. Sometimes the patient will be in the bed for a couple of days when they have a exacerbation of this illness. Decreasing stress can be helpful, believe it or not, with vertigo. Decreasing salt intake also can be helpful. Tinnitus, if you haven't seen that word before, certainly you have by now, but ringing in the ears, that can be a first sign of ototoxicity. So always assess your patient, and if they report ringing in the ears, then